If you work in an area with low TB rates and relatively few foreign-born patients, you might have only a few patients each week who warrant TB skin testing. You'll still need to store the PPD fluid correctly and place and interpret the skin test meticulously. See the resources section for materials to help with TST placement and interpretation. Here are a few highlights. The PPD should be stored in the bottle and clearly labeled in the refrigerator, and should be discarded after the bottle has been open for 1 month. Healthcare providers who administer the TST should be trained and periodically evaluated on skin testing technique. 0.1 milliliters of PPD material should be injected intradermally into the volar aspect of the forearm. A correct placement yields a pale, distinct wheal, which is raised for several minutes, not a vague hump which drops down immediately. Many people place it incorrectly. The TST result should not be read by parents. It should be read by a trained healthcare professional 48 to 72 hours after placement. A positive test has distinct induration, not just erythema. Detecting the edge of induration is key to correct reading. So bend the arm at the elbow, look with indirect light, feel gently with your non-dominant hand or run a pen across the induration, and measure and record the TST result in millimeters of induration perpendicular to the long axis of the arm. What if the TST site is indurated when the child returns for reading? How do you interpret the result? To increase the positive and negative predictive value of the test, breakpoints for interpretation have been developed. A small area of induration, greater than or equal to 5 millimeters, is considered to be positive only if the child is immunocompromised, is a contact to a known or suspected case of TB, or has clinical or radiographic evidence of TB. Greater than or equal to 10 millimeters of induration is considered a positive result for any child with intermediate risk, such as age less than 4 years, medical conditions predisposing them to TB, or increased risk of TB exposure. Greater than or equal to 15 millimeters is considered positive if the child has no risk for infection or disease. Presumably, these children will not be skin tested. On the last slide, we reviewed the possibility of the TST results representing a false positive test. The IGRA tests are also not perfect. The IGRA blood tests each have a single cutoff, and interpretation is not based on risk or clinical features. These cutoffs were chosen to optimize both sensitivity and specificity, but there can be false positives and false negatives. Some low-grade positive IGRA results may be false positives. However, early infections and severe disease may also be associated with low-grade positive results. After any positive TST or IGRA, you should evaluate the child for TB disease with a history and physical exam, as well as chest radiograph. New guidance suggests that children with low-grade positive IGRA results and without specific risk factors or exposure history and without signs or symptoms of TB disease should have a repeat TST or IGRA before considering them to have TB infection. Here's the guidance found in the 2024 American Academy of Pediatrics Red Book. Low-grade false positive IGRA results occur in some individuals. Perform a second diagnostic test, either an IGRA or a TST, for children without specific TB risk factors other than foreign birth or travel, and an unexpected low-level positive IGRA result. The cut points for each test are defined on the slide. The child is considered infected only if both the original and repeated tests are positive. In my practice, I have found that a repeat IGRA, whether performed immediately or in a few months, often shows results in the same range. I've started to use the TST rather than IGRA with good results. Most of these low-risk children have had 0 millimeters induration, but one older child had a 15 millimeter TST reaction. These results allowed me to make firm plans with the parents. So now you've tested your patient. If you've used TST, miraculously, they came back for the reading and you have your interpretation. What do you do now? First, document the result as millimeters of induration in the chart and on the child's vaccine record. If the test is negative, advise the family to return to the clinic if the area of induration becomes bigger in the next few days. A positive skin test can be read and interpreted up to 7 days after placement. If you tested with an IGRA, document the result in the chart
and on the child's vaccine record. The next time the child comes for a well-child visit, repeat the questionnaire procedure. Repeat the TB test only if the child has a new risk factor, such as travel to a high-risk area, exposure to someone with a newly identified positive test, or someone diagnosed with TB. If the TB test is positive, things get a little more interesting.
The first thing to do is to determine whether the child has TB, otherwise known as active tuberculosis or TB disease, or whether he or she has inactive or latent TB infection, abbreviated as LTBI. TB means the child has metabolically active Mycobacterium tuberculosis bacteria in some part of the body. It does not necessarily mean that the child has symptoms of TB, because many children are completely or relatively asymptomatic at the time they're diagnosed with TB in the U.S. LTBI means that the organism is dormant, and the physical exam and radiograph are normal. In order to decide TB or not TB, perform a focused history, a physical exam, and a chest radiograph. The history should include information about the child's health and information regarding where the child might have acquired TB. A coughing household member might just be the source case for the child. The physical exam should mostly be geared toward identifying sites of tuberculosis outside the chest, since these will not be identified on the chest radiograph. You'll especially be looking for evidence of disseminated disease with temperature and growth parameters, meningitis by evaluating the level of alertness and meningeal signs, scrofula by examining peripheral lymph nodes, peritonitis by examining the abdomen, and bone and joint disease by palpating the back and extremities. Extrapulmonary TB can affect any part of the body from head to toe, so make sure to engage the parents while you examine the child. They might point out some eye, ear, or skin finding which you might have overlooked.
Of course, you'll auscultate the chest, but I'll warn you, lung findings are often relatively modest, even with an impressively abnormal chest radiograph. Of all age groups, infants and adolescents are most likely to have rales, decreased breath sounds, and increased worker breathing. A few details about the chest radiograph. I always order a 2-view chest radiograph for children who might have TB. But some programs perform only a frontal view on children who are 5 years of age and older, and they reserve the lateral view for those younger children and those with difficult to interpret frontal views. The 2-view chest radiograph helps to identify one of the most common abnormalities of pediatric TB chest radiographs, intrathoracic lymphadenopathy. Make sure to mention the symptoms and the possibility of TB on the radiology order form. Preferably, the film will be interpreted the same day by a radiologist experienced with children and tuberculosis. If the radiograph cannot be interpreted immediately, do not start any TB therapy. Wait until TB has been ruled out before starting LTBI treatment. If the chest radiograph and physical exam are normal, the child with a positive TB test is diagnosed as having LTBI, latent TB infection. If we are truly screening only people with TB risk factors, everyone we identify as having LTBI should be treated. Some providers do not aggressively treat LTBI in their adult patients, but in pediatrics, we really should try to fully treat all kids identified as having LTBI. Why? Because the treatment has fewer side effects in children than it does in adults. Because young children are more likely to develop TB once infected than are adults, and because young children were, by definition, infected recently, increasing the risk of progression to TB. I'll review treatment of LTBI later in the program, but the good news is that we have shorter treatment regimens that make adherence easier. Okay, now we get to a little sticky point. It turns out that not all children who have a positive TST or IGRA actually have LTBI. That's why it's so important to test only those kids with risk factors. These tests have much better specificity when used only for children at high risk of truly having TB infection. On this slide, we'll talk about how to address the possibility of false positive TST. First, any child who has a positive TST or IGRA, by standard definitions, needs to have a physical exam and a chest radiograph to rule out TB disease. If a child has a positive TST, I offer LTBI treatment. I explain that babies and toddlers have the highest risk of progressing to TB disease, and encourage the family to accept treatment. If the family is reluctant to accept the diagnosis, I talk to them about the blood tests, sensitivity, and improved specificity in children who have received BCG. If the family indicates that a blood test result would help them be comfortable with the LTBI diagnosis and they would be open to LTBI treatment if the blood test is positive, I proceed with the IGRA testing. If the IGRA test is negative, I counsel the family that it is unlikely, but not impossible, that the child has LTBI. I agree that LTBI treatment is probably not necessary. However, I emphasize that no test is perfect. If the child were to develop signs or symptoms of TB disease, like prolonged cough, unexplained fever or weight loss, or poor weight gain, etc., they should come back into care and remind the healthcare team that the child had a positive TST and did not take treatment. To reiterate, I only do this strategy after ruling out TB disease by chest radiograph and physical exam, and I always offer LTBI treatment to any family whose child has a positive TST. In summary, we have just reviewed a very common scenario in pediatric well child care. Screening for TB is not performed by routine or universal TB testing. Rather, targeted testing includes reviewing TB exposure and population risk factors and testing only children with new exposure risks since their last TB test. If a child is found to have a positive TB test, he or she should undergo a chest radiograph and a focused history and physical in order to discern whether the child has TB or LTBI.